Thank you so much once again, friends. I once again welcome all of you to our anniversary lecture. We have many doyens of neonatology who are attending our annual anniversary lecture. I welcome all of them and invite any of them who wants to speak a few words. May I invite Dr. Surendra Singh Bish, the Secretary General of National Neonatology Forum India.
Thank you, Dr. VC Manoj. I hope I'm audible.
Yes, you are audible.
So first and foremost, heartiest congratulations from National Neonatology Forum. We are so glad, excited, and happy. And we saw the kind of the gratitude, the compliments, and the fervor, happiness which were exuded by many of the people who gave messages right now. They were actually representing the feelings of thousands and thousands of newborn specialists across the globe, and particularly from India, who got benefited in the last 4 years from the level of from this level of knowledge sharing, from the level of this kind of information, the ease, the democratic way of spreading the latest developments, the real developments, the technologies which are about to come, the experiences of the past, with the insights into the new developments which are going around. All that was possible because there were legions. There are legions from the past. There are legions who are working now, and the legions who are going into future also. All that spectrum of the people. In fact, sometimes the legion said, "I'm not that a legion," but the work was so legendary. The kind of information, and it has been always created an awe among the people who have listened to and witnessed these learn from legends in seminars. In fact, all the fellows, wherever I've gone in the neonatal centers across India, they've seen your videos. They recommend your videos. They recall and then revisit your videos again and again to know anything which is coming later for their exam, for their preparation of seminars. This is the kind of work which has gone in last 4 years, and the repository which has come up, the repository which you have shared about the series of lectures is one of a kind in the whole world. I think, and I think Dr. Professor Ellen and Professor Ola will certainly agree to it, that this kind of repository has never been made anywhere in the world in any of the websites which are available. So we are really thankful, Dr. Manoj. You are our next president for the year 2025. As the incoming president of the National Neonatology Forum, you have shown the world that India and NNF can produce this kind of a repository and this kind of knowledge sharing. Thank you all. Thank you all from us.
Thank you, Dr. Surendra. Friends, we have with us today a true legend of neonatology, Prof. Saugstad, who had incidentally delivered our inaugural lecture on 19th June 2020. Once again here with us to deliver the 4th anniversary lecture. Thank you so much, sir. We are so fortunate to have you with us today. Now, may I request another doyen of neonatology, Professor Elon Shani, to introduce the Professor Ola Saugstad officially. Dr. Elon Shani is a neonatologist and director of neonatal care, Soroka University Medical Center, Ben Gurion University of Negev, Israel. Over to you, Elon.
Well, Dr. Manoj, really thank you very much for inviting me to introduce and present Professor Ola Saugstad. It is really a great honor for me, and I think that it's the right choice to ask Dr. Ola to to be in this 4 years anniversary of this incredible Learn from the Legends project. Professor Ola, whose passion is divided between soccer and medicine, is a research professor at Oslo University Hospital and professor of neonatology at Northwestern University's Feinberg School of Medicine in Chicago. He is a professor emeritus in pediatrics at the University of Oslo and was director of the Department of Pediatric Research at Oslo University Hospital from 1991 and 2017. And I'm sure there is much more than this. He's also the author of nearly 600 publications and 5 books, and is the honorary member in many European pediatric societies and the recipient of many awards. As a research fellow in the 80s of the last century, before pediatric residency and neonatal fellowship, he made the connection between hypoxanthine, free radicals, and oxygen, which was the starting point for revolutionizing our resuscitating practices in the delivery room and stop using oxygen as the default for any resuscitation. Personally, I first met Professor Saugstad in my first professional trip to India, when my chief of neonatology, Professor Mickey Karplis, took me for a National Neonatal Forum conference in Chandigarh to present the cerebral function monitoring. This is when I was introduced to the idea that our default use of oxygen in the delivery room that seemed then so obvious deserves a second thought. Today, Professor Saugstad will talk about changes in the way we handle newborns in the delivery room. So please, Ola, the stage is yours. We're all happy to hear you.
Thank you so much, Elon, for this nice introduction. And yeah, you bring back very nice memories from our first meeting in India almost 30 years ago. We had a great time. And I had to say thank you also to Manoj for your kind invitation. It's a great honor to give this lecture. Can you imagine it's 4 years since we started this series, which has been very successful as far as I understand. So I'm very grateful, and as you know, India is very much at my heart. My first visit to India was more than 30 years ago, and I've been following the development not only in neonatology, Indian neonatology, but also in the Indian society, and it's very impressive what I've seen. So now I will try to share the screen, if I'm able to do that. So do you see my screen now?
Yes, sir. Perfectly.
Yeah. So thank you for also giving me the opportunity to talk about what's new in the delivery room handling of the newborn, filling the gaps. And the reason for this title is that I'm just publishing a paper with exactly the same title, How to Fill the Gaps in Newborn Delivery Room Handling. So here are my disclosures. And the learning objectives of this lecture is to understand the newborn resuscitation algorithm, but also to understand that there is lack of evidence regarding newborn resuscitation, and also where are the gaps we need to fill. So delivery room handling is really a big topic, and you see here all these issues we could talk about, and I don't have time during my 45 minutes or so to talk about all these aspects, but I will comment some of them and maybe focus mostly on cord clamping today. So, but what is delivery room handling of the newborn? I asked artificial intelligence, ChatGPT, a year ago, and this is the answer, which I found was quite interesting. Delivery room handling of the newborn refers to the immediate care provided to a newborn baby in the first few minutes after birth. The handling is usually done by trained healthcare professionals, including obstetricians, midwives, nurses, and neonatologists. Overall, the goal of delivery room handling of the newborn is to ensure the baby's smooth transition from the womb to the outside world and to prevent or address any immediate health concerns. And ChatGPT, they listed 8 topics which is covered in this term, delivery room handling. Well, I asked for an update. So yesterday I asked my friend ChatGPT again, what is delivery room handling of newborn? And I got a little bit different answer, but they listed up also the main issues: to prevent heat loss, maintain an open airway, initiate breathing, assess breathing and heart rate, and evaluate color and tone. And I think this is very familiar to all of the audience here. And ChatGPT added that further resuscitation steps may be needed if the baby does not respond to the initial steps. One should continue with advanced resuscitation procedures, including chest compressions and medications as needed. I also asked ChatGPT yesterday whether or not delivery room handling of the newborn is evidence-based. And I got a very enthusiastic reply that handling of newborns in the delivery room is indeed evidence-based, with practices continually refined based on the latest research and clinical guidelines. I won't say that is wrong, but at the end of my lecture, I will try to show you and convince you that newborn resuscitation is far from being evidence-based. There are a lot of gaps in the algorithm. Well, in order to understand what's happening during the transition and in the delivery room, we need to know a little bit about developmental aspects of the fetus. And this is from a paper I published recently with Shankaran and Lakshmi Rushma. And as you all know, Satya and Lakshmi Rushma is a very skilled medical illustrator. And so this is one of his drawings. So it shows how the pulmonary vascular resistance reaches a nadir here around 30 weeks of gestation, and then increases towards term. And of course, after birth, it drops quite dramatically, as you all know. And here's the systemic vascular resistance slowly increasing towards term, and then rapidly increases after birth. And this nadir of the pulmonary vascular resistance happens approximately during the sacral stage of the lung development. So this can explain some of the reactions of babies born around 30 weeks compared with, for instance, 25 weeks or 35 weeks. Now, there are a number of factors that influence the outcome of delivery room handling, and we summarize this in a paper we published with some colleagues from Northwestern University 5 years ago now. But you see here there are a number of antenatal factors as chorioamnionitis, mode of delivery, the use of antenatal steroids, maternal BMI, and maternal nutrition. And then in the delivery room, there are a number of factors which may influence the outcome, which we have listed here. For instance, tidal volume, oxygen, flow rate, cord clamping, PEEP, surfactant, temperature control, and so forth. So there are a number of maternal and antenatal factors that are important for the outcome. And I will mention a few of these now at the start of the lecture. And I'll start out with this figure. This is from a paper we published in JAMA. It's 10 years ago now. It shows that there is an association between maternal BMI, and that is BMI before the pregnancy, and the outcome of the baby. And this is perinatal death. And you see here, this is a kind of a J-shaped curve. You have the lowest perinatal mortality where if the mother has a BMI around 20, and then you see it increases steadily with increasing BMI. And here is an update of this study, which is not published yet, but it's based on 23 million singleton births from US. And you see again this U-shaped curve, and you see the lowest mortality. In this case, it's infant mortality. The lowest mortality is with a BMI around 18 to 22. So this illustrates how important it is that we teach young women that they should control their BMI before they become pregnant. And here again, we see that all mortality indicators follow the same shape, this U-shaped shape regarding mortality and BMI. What about the use of antenatal steroids? Well, these are data from the European registry e-newborn, which included 38,000 babies born between 2014 to 16 with gestation age between 22 and 32 weeks. And here you see that 90% or more of these babies, they have received antenatal steroids, but not all of them had a complete course. 20% of them had an incomplete steroid course. Does it matter? Well, if you look at the risk of death, see that a complete course of antenatal steroids reduces mortality approximately 50%, but you see also an incomplete course reduces mortality almost the same level. So that means that even if we are not able to fulfill or finish a complete course, we should start antenatal steroids as soon as we think there is an indication for that. What about mode of delivery? Well, this is a study, is also 10 years old now, from Yi and co-workers, showing that there is increased neonatal mortality with an increased C-section rate, but only up to 10%. If the C-section rate increases to more than 10%, there's no effect on the mortality rate. Of course, morbidity could be changed, but this indicates that perhaps there's no advantage to increase the C-section rate above 10 or maybe 20%. And I mentioned this because I know that the C-section rate in many parts of the world is extremely high. I don't know the numbers in India, but I think it is important as neonatologists that we talk with our obstetrical colleagues and try to keep the C-section rate at a reasonable level, because it matters. And this shows that even up to term, this is babies born after C-section, after 37, up to term, and you see this is serious respiratory morbidity, and it's extremely high compared with vaginal delivery, all the way up to 39 weeks. So I think we have a responsibility to teach the community that we don't want too high C-section rate. Now back to the European registry. This is the distribution of the babies, and you see we have a peak here around 30, 31, 32 weeks of gestation. And here is the mortality rate, and you see that there is an kind of inverse exponential relation between the gestation age and neonatal mortality. So what is the need of resuscitation for babies less than 32 weeks? Well, again, according to the European registry, we see here that babies from 24 to 28 weeks, 80–90% of them would need resuscitation, and it drops, but even at 32 weeks, 60% or between 50 and 60% would need some resuscitation. And we have split this up into what we call basic resuscitation, which is bag and mask plus oxygen, and more advanced resuscitation. And we see that very few of the smallest babies need basic advanced resuscitation, basic resuscitation, but around 32 weeks, 60% would need basic resuscitation. Advanced resuscitation is more common among the smallest immature babies, which is not a surprise, as you can see here. Well, does it matter Yeah, it matters because we have shown from these data, European data, that risk of mortality, risk of death is increased approximately twofold for babies who need advanced resuscitation compared with basic resuscitation. Now, very recently, I published together with my friend Satya and Lakshman this commentary in Pediatric Research. Actually, it comes out in this issue, the June issue of Pediatric Research, to intubate or not to intubate. Is that the question? And well, this is quite a complex figure, but illustration. But what we have done here, or what Satyan has done when he drew this, was that these boxes with red indicates conditions with poor prognosis. For instance, low preductal saturation heart rate by 5 minutes, or prolonged intubation, or even laryngoscopy and endotracheal intubation might be a risk. So what we wrote in this commentary is that it's not clear if initial intubation in the delivery room is associated with poor outcome, especially if the infant is promptly extubated via INSURE to CPAP. But we add that intubation should be carried out if needed, especially in extremely preterm infants, less 25 weeks or less, with persistent high FiO2, need respiratory acidosis or distress despite non-invasive surfactant delivery. Simultaneously, we should develop further techniques to avoid intubation in preterm infants. So this is the ILCOR algorithm for newborn resuscitation, and this is the version from 2010. In 2010, ILCOR introduced this term, the golden minute, the first minute of life, and it was actually split up in two halves, 30 seconds each. But ILCOR had forgotten something very important. They didn't define when is the golden minute. When should we start the clock? When the shoulders are out, when you cut the cord, when the baby is on the resuscitation table. I think we all should agree that we start the clock when the whole baby is out. And this is, of course, important when we're talking about APGAR scoring and the golden minute per se. So in 2010, you're supposed to ask 3 questions for each and every delivery you attend. Is the baby born at term or not? Is the baby breathing? And how is the muscle tone? And we now time only the first 60 seconds. And what was also important in these guidelines was that for the first time, ILCOR said that you should start with air instead of 100% oxygen for term or near-term infants. And you should consider to monitor saturation if you have a pulse oximeter at hand. You start ventilation if the heart rate is less than 100 beats per minute, or there is apnea or insufficient breathing within 30 seconds after drying and stimulation. So here's a close-up. The first 30 seconds, you're supposed to dry the baby, keep the baby warm, wrap it into plastic if it's less than 28 weeks, and stimulate it to breathe, position the airways correctly, and monitor heart rate and breathing rate. And within the golden minute, respiratory support should be established, provided the baby needs help to breathe, and also put on a pulse oximeter if it is available. From 2010 to 2015, there were not much changes in the guidelines. What they did was that they stopped splitting the golden minute in 2 parts, and they added this maintain temperature line to remind us how important it is to keep the baby warm during the delivery room procedures. Now, how should we assess the heart rate at birth? As you know, there are several methods to do that. Palpation, for instance, stethoscope, pulse oximeter, or ECG. Well, ILCOR suggests that heart rate immediately after birth should be determined by ECG, in 2015. Well, I disagreed on these recommendations, because I know that very few units around the world, also in my part of the world, are using ECG in the delivery room. At least I didn't do it at that time. So this is a study done by Colin Morley's group some years ago now, but where they compared heart rate assessment. They compared auscultation with palpation, and you see that palpating the umbilical cord is not very accurate. So auscultation is better. And this is a study from Van Vonderen now 9 years ago, where they compared the heart rate assessed by ECG, the green symbols here, versus pulse oximetry. And again, you see that ECG is superior to pulse oximetry. There was a European survey about delivery room handling very recently, and you see that stethoscope is still the most used method to assess heart rate, even in Europe. But approximately 30% of the units now have ECG available, and 20-25% still are palpating umbilical cord to assess heart rate. So heart rate by auscultation is inaccurate, and it underestimates the heart rate obtained by ECG. But together with Roger Sol, I argued some years ago that if the heart rate is counted 10 instead of 6 seconds, much of this inaccuracy could be eliminated. A reliable heart rate is obtained earlier with ECG than with pulse oximetry. In one study, it was 84 seconds difference. And we also know that number of the ECG signals, at least in the first ECG instruments we had, they have to be excluded due to technical problems. And we also know that there's a lot of so-called pulseless electrical activity. In animal models with asphyxia, it's been shown that up to 50% of the activity is so-called PEAs. But new devices are under development based on Bluetooth technology. But I will argue that auscultation is still the gold standard for assessing heart rate at birth. I would like to hear your opinion about that later. A few words about sustained inflation. And it was summarized some years ago in a Cochrane review, and it was shown that sustained inflation was not better than intermittent ventilation regarding mortality. Need for intubation, need for or duration of respiratory support, or bronchopulmonary dysplasia showed no evidence of relevant benefit for sustained inflation compared with intermittent ventilation. But the duration of mechanical ventilation was shortened in the sustained inflation group. But as you might know, all of you, is that the so-called SAIL study, which tested this out, was stopped due to adverse effects. It was increased mortality in the sustained inflation group. So I think personally, I'm not promoting sustained inflation anymore. And now I'll focus on cord clamping. And this is, again, from the paper I published with Sankaran and Lakshmi Rushama. And this is just to remind us what happens when we clamp the cord. And here you see that PaO2 increases rapidly the first 2 minutes after birth. And we see also here that the pulmonary blood flow increases, systemic arterial pressure increases, and pulmonary arterial pressure decreases, as you all know. Now, if we wait to clamp the cord, if we wait 1 minute, it has been shown that on average, 70% of the blood which is can be transfused from the placenta to the baby has reached the baby. So for that reason, many say that we don't need to wait more than 60 seconds, but if we wait another 60 seconds, another almost 20% of blood reaches the baby. So how long should we wait? Well, this is a study showing, this is from Ola Andersson in Sweden, show that compared to 5 seconds of cord clamping, 1 minute and even 3 minutes, you increase the blood volume significantly, as you can see here. So maybe we should wait 3 minutes. All the recommendations today say that we should delay cord clamping 30 to 60 seconds. Are there any risks by delaying cord clamping, as overtransfusion, polycythemia, jaundice, hypothermia, pulmonary hypertension, or delayed resuscitation? Well, according to some authors, there is no risks. And these authors, Bruckner and co-workers, they suggested that one should wait at least 60 seconds in a high environment level or country or environment, and at least 180 seconds in limited resource environments. And it's been shown that delayed cord clamping reduces incidence of anemia and iron deficiency and improves hemodynamic variables. And they also underline that there is no evidence that delayed cord clamping results in higher rates of phototherapy. I have received comments from colleagues from many places in the world who are a little bit worried about the risk of hyperbilirubinemia after delayed cord clamping. According to experts, they say there's no increased risk. Very recently, American Heart Association, American Academy of Pediatrics came out with updated guidelines regarding umbilical cord management, and for term and near-term babies 34 weeks or more who do not require resuscitation, they recommend now delayed cord clamping 30 seconds or more. And for non-vigorous term and late preterm infants, intact cord milking may be reasonable when compared to early cord clamping. And for term and late preterm newborn infants, 34 weeks or more, who do not require resuscitation, intact cord milking is not known to be beneficial when compared to delayed cord clamping. And recommendation for preterm babies is that babies less than 34 weeks who do not require resuscitation, delaying cord clamping 30 seconds or more can be beneficial when compared to early cord clamping. And for preterm newborns between 28 and 34 weeks who do not require resuscitation and in whom delayed cord clamping cannot be performed, intact cord milking may be reasonable. And for preterm newborn infants less than 28 weeks, intact cord milking is not recommended, and I will show you why in a minute or so. Now, in November, 2 important papers regarding this topic was published by the same group of authors in The Lancet. And the first paper with the title Deferred Cord Clamping, Cord Milking, and Immediate Cord Clamping at Preterm Birth. And this was a systematic review and a so-called individual participant data meta-analysis. In this study, they included more than 6,000 infants from 48 trials, all with a gestation age less than 37 weeks. And so they practiced deferred cord clamping, more than 30 seconds, or cord milking, and compared it with immediate cord clamping. And outcome was death before discharge. And this is what they found. Deferred cord clamping versus immediate cord clamping reduced mortality with approximately 30%. Odds ratio 0.68, and this was significant. However, when they compared umbilical cord milking with immediate cord clamping, there was no significant difference, although there was a tendency, odds ratio 0.73, but it was not significant in this study. They also looked at some secondary outcome measures and found that delayed cord clamping reduced the need for blood transfusion. And this is, of course, known for a long time now. And the second paper they published in the same issue of The Lancet was about short, medium, and long deferral of umbilical cord clamping compared with umbilical cord milking and immediate clamping. Again, it was preterm babies, less than 37 weeks, more than 6,000 babies, 47 trials, and short deferral of cord clamping was defined as 15 to 45 seconds, medium 45 to 120 seconds, and long 120 seconds or more, or intact cord milking compared with immediate clamping. And again, outcome was death before discharge. And this is what they found. Actually, they didn't find any difference for short deferral or medium deferral. However, long deferral, 2 minutes or more, significantly reduced mortality, 70%. It's a very dramatic effect. No effect of cord milking, as you can see here. So the question is now, should we, when you talk about delayed cord clamping, should we talk about 2 minutes or perhaps 3 minutes instead of 1 minute? And this is a study where they looked at cord clamping after 3 minutes, and they didn't find any adverse effects regarding bilirubinemia or postpartum hemorrhage. So they concluded that umbilical cord clamping times beyond 3 minutes in vaginal deliveries were not associated with negative short-term outcomes in newborns and were associated with a smaller maternal postpartum blood loss. Although cord clamping time as long as 6 minutes could be considered as safe, further research is needed to decide the optimal timing. I don't know how the practice is in India, and maybe, Manu, we could ask a question to the audience at this stage. I just want to mention that in Sweden now, the midwives in general, they wait 6 minutes before they clamp the cord. Manu, do you have a question to the audience?
Give me a second, sir.
Yeah.
Yeah, here it goes.
Should we wait for the answer?
Yes, sir, they are responding. So probably we'll give them 10 more seconds.
Yeah.
So these are the results, sir.
Okay. Delayed cord clamping, 80%. Physiological based cord clamping, I'll talk about that in a minute. 16%. Early cord clamping, 5%. Okay, so thank you. That was interesting. So let's move on. Just a few more words about cord milking, because also in November, a paper came out in Pediatrics by Anu Kateria's group in San Diego about umbilical cord milking versus delayed cord clamping in babies between 28 to 32 weeks. And what I found was that in overall in these babies, there was a significantly increased risk of intraventricular hemorrhage, grade 3 and 4. However, when they looked at the different strata, you see that this significance was only for babies between 23 up to 28 weeks of gestation. So severe intraventricular hemorrhage is associated with milking versus delayed cord clamping and increased the risk approximately fourfold. So this is the data from this study showing that. So what is the reason for that? Well, I think it's quite obvious that you know that the immature brain doesn't have an autoregulation, and this will increase the right to left ductal shunt, which result in fluctuations in flow to an immature brain with fragile germinal matrix, as you can see here from this illustration. And now a few words about physiological cord clamping. That means that you should start to ventilate the baby, or the baby should breathe, and then cut the cord. You shouldn't time it to 30 seconds or 60 seconds. Well, this was a study published 2 years ago now by Badurdin from Australia, from Melbourne, about physiological-based cord clamping for babies 32 weeks or more. And they had they compared physiological-based cord clamping with early cord clamping, and heart rate between 1 and 2 minutes after birth was the primary outcome. Now, these authors didn't find any differences at all regarding time to first cry, APGAR score, or need of respiratory support. So they concluded that physiologically based cord clamping does not provide additional benefit over early cord clamping performed after initial drying and stimulation in terms of key physiological markers of transition. And very recently, I listened to a lecture by this man, Ronnie Knoll from the Netherlands, about the ABC3 trial. I don't think the trial has been published. It was not on Medline PubMed yet, but I know the results. And in this study, they practiced physiologically-based cord clamping in babies less than 30 weeks. And the outcome was survival without major cerebral injury or necrotizing enterocolitis. And they didn't find any differences between the two groups. So we had at least 2 studies which are quite disappointing when you talk about physiological-based cord clamping. And then a few words about resuscitation with intact cord versus clamped cord. And again, it was a very recent published randomized study. And in this study, they had 71 babies with intact cord resuscitation, babies 34 weeks or more of gestation versus 91 with early cord clamping and resuscitation. And outcome was the so-called expanded APGAR score at 5 minutes after birth. So yes, they found that they had a slightly higher expanded APGAR score, 15 versus 14. But I don't think this has any clinical relevance. The difference is so small. And there's now another study on this also with disappointing results regarding intact cord resuscitation. I think we have to wait to more data before we really jump on using this method. A few words about ventilatory support after birth. Which devices and interfaces should we use when we administer positive pressure ventilation? Again, there was an update from American Academy of Pediatrics, American Heart Association, just 6 months ago. And they concluded that it can be beneficial to use a T-piece resuscitator instead of self-inflating bag with or without a positive end expiratory pressure valve for administering positive pressure ventilation to newborn infants, particularly for preterm infants. So they also added that because both T-piece resuscitators and flow-inflating bags require a compressed gas source, a self-inflating bag should be available as backup in the event of compressed gas failure when using either of these devices. And they also point on the possibility to use the so-called supraglottic airway, to establish a supraglottic airway. And so they now recommend that they state that it may be reasonable to use a supraglottic airway as the primary interface to administer positive pressure ventilation instead of a face mask for newborn infants delivered at 34 weeks of gestation or more. So there was a big meta-analysis, 6 randomized controlled trials, more than 1,800 infants, about 34 weeks. And it showed that the duration of positive pressure ventilation and time until heart rate reached 100 beats per minute were shorter with a supraglottic airway compared with face mask. And there is the study also shows that the need of intubation is reduced using a supraglottic airway compared with face mask ventilation. So American Academy has 10 take-home messages for term and late preterm newborn infants about 34 weeks gestation who do not require resuscitation. Delayed cord clamping 30 seconds or more can be beneficial compared with early cord clamping. Maybe we have to change this to now to 2 minutes instead of 30 seconds or more. For term and late preterm newborn infants above 34 weeks gestation who do not require resuscitation, intact cord milking is not known to be beneficial compared with delayed cord clamping. And for non-vigorous term and late preterm newborn infants, 35 to 42 weeks of gestation, intact cord milking may be reasonable compared with early cord clamping. And for preterm newborn infants, less than 34 weeks gestation who do not require resuscitation, delaying cord clamping 30 seconds or more can be beneficial. For preterm infants less than 28 weeks gestation, intact cord milking is not recommended. Effective positive pressure ventilation is the priority in newborn infants who need support after birth. Using a T-piece resuscitator to deliver positive pressure ventilation is preferred to the use of a self-inflating bag. And because both T-piece resuscitators and flow-inflating bags require a compressed gas source to function, a self-inflating bag should be available as a backup. And use of a supraglottic airway may be considered as the primary interface to administer positive pressure ventilation instead of a face mask for newborn infants delivered at 34 weeks gestation or more. And now I will talk a little bit about chest compression. Mano, do I have a few more minutes?
Sure, sir. Please go ahead.
Okay, yeah. So I think, again, this is from the same paper I referred to. We published now, it's 1.5 years ago. But I think it's very important practically because it shows, this is from animal studies from Satya and Lakshmanushma's lab, fetal lambs, but it shows that if you're giving adrenaline, epinephrine, and you're doing chest compression, so you're giving adrenaline, it seems that the time to return of sustained circulation is reduced significantly if you flush the adrenaline with 2.5 ml instead of 1 ml. And so it increases the time, or it increases the success of ROSC from 43% to 80%. And if you flush with 10 ml, it increases the success rate to 89%. So I think this is an important, factor you should be aware of. And when we talk about chest compressions, which FiO2 should we apply? Well, there has been some animal studies, or actually also meta-analysis we published some years ago showing that you can actually use air as well as 100% oxygen. On the other hand, it has been shown that during chest compressions, even if you use 100% oxygen, the PO2 doesn't increase to very high levels. So it might be correct to say that you should start chest compressions with 100% oxygen. And this is what also the American guidelines say, start with 100% oxygen. However, The American guidelines, they say that you should wean slowly as soon as return of spontaneous circulation, ROSC, has been achieved. You should wean slowly. Now, there's several studies now, animal studies, showing that if you wean slowly, you get this very high PO2 peak. This is in the brain, you see here, and this is the study from Melbourne. And this is a study from Lakshmin Rushma's lab, and this is the cerebral oxygen delivery. And the red symbols here represent animals where there was a slow weaning from 100% oxygen. You see that it's an enormous overshoot. You get too much oxygen to this brain. By contrast, if you wean rapidly, immediately to room air, 21%, you see that you're in the target, more or less immediately. So what we now recommend is that, yes, if you do chest compressions, you can do the compressions with 100% oxygen, but you should wean immediately to air as soon as return of spontaneous circulation has been achieved. I haven't talked much about oxygen and oxygenation in this lecture, but here are some of the recommendations. For babies 35 weeks or more, start with 21%. 29 to 34 weeks, start with 21 to 30%. And babies less than 28 weeks, start with at least 30% oxygen. We have a paper in press in JAMA Pediatrics. It actually comes out in 2 days or 3 days now, indicating that it is better to start high than low in these most immature babies. But we don't know what is the optimal, but it seems that even 30% oxygen is too low for these babies. During chest compressions, after return of spontaneous circulation, we immediately do 21% in term babies without lung disease. If there's a preterm baby and there's a lung disease, you can maybe wean to 30-40% and then titrate based on preductal oxygen saturations. And just a couple of words about heat loss, which is important. And as you all know, we try to reduce heat loss, prevent heat loss. We place babies less than 28 weeks in plastic. And the question is if it matters. Well, this is a meta-analysis. This is a Cochrane review showing that actually there was no effect on major brain injury by this device or this method, and there was no effect on mortality. Still, I think we want to, of course, avoid hypothermia in these babies. And the European survey I referred to earlier shows that there are a number of ways to keep the baby warm, especially the delivery room, temperature, 26 degrees. It's very high. It's difficult for the obstetrician to tolerate. We could also preheat the infant warmer, plastic bag wraps, servo control, temperature probes, thermal mattresses, caps, and pre-warmed towels and heated humidified gases. And I just want to remind you about this important paper about kangaroo mother care, published in New England Journal of Medicine a couple of years ago, shows that it lowers mortality and it stimulates the early initiation of breastfeeding, and the baby is colonized with maternal microbiome, which I think is an advantage, and it also gets warmth from the heat from the mother. So to summarize delivery room handling, we published this paper 3 years ago now, where we summarized all these guidelines, and I don't have time to go through this. You can find this paper in Neonatology, and we summarized all these topics, and we also tried to distinguish between low resource areas with high resource areas. So for those who are interested, and here we have the European guidelines published in 2023. It's recommended delayed cord clamping for at least 60 seconds is recommended. Maybe we have to change this to 2 minutes in the new guidelines coming out next year. TPs should be used rather than bag and mask. And spontaneously breathing preterm infants should be stabilized using CPAP. Oxygen should be controlled using a blender. Use initial FiO2 of 0.30 for babies less than 28 weeks, and between 21 and 30% for those between 28 and 31 weeks, and room air for 32 weeks and above. And FiO2 should be adjusted up or down, guided by pulse oximetry. And which I didn't talk about in this lecture, we aim to get an oxygen saturation of at least 80% and a heart rate above 100 within 5 minutes. And intubation should be reserved for babies not responding to positive pressure ventilation via face mask or nasal prongs, and plastic bags or occlusive wrapping under radiant warmers and humidified gas should be used during stabilization for babies less than 28 weeks. And now the gap, finally. We published this 3 years ago, a critical review of the 2020 International Liaison Committee, the ILCOR guidelines. And out of all the procedures which were changed from 2015 to 2020, there was no strong evidence for any of them. For instance, briefing or debriefing, which was a new topic, there's no evidence behind that. Non-vigorous delivered through meconium-stayed amniotic fluid, weak or low. Evidence, sustained inflation, weak, low. Epinephrine, adrenaline, weak, very low. Vascular access, weak, very low. Return of spontaneous circulation, weak, very low. So we don't have any hard evidence. And in this paper, which is now coming out very soon, we found that of the 22 procedures reviewed in the 2020 ILCOR recommendations, the evidence was either low, very low, or non-existing for all the procedures. The strength of recommendation is weak or non-existing for most topics discussed. And there is a special challenge for low and middle income countries. So a key message in this article is that newborn resuscitation is still not evidence-based, although great progress has been achieved in the last 30 years. However, there are still numerous gaps to fill. We have identified several knowledge gaps which should be prioritized in future research. Randomized controlled trials are needed. The challenge of obtaining evidence-based knowledge from low and middle income countries should be focused on in future research, and specific studies in these countries are therefore urgently needed, because we aim at a world where every newborn counts, everywhere. Thank you very much for your attention. Here are some references for those who are interested. And here is a picture of Mount Saugstad in Canada. It's not named after me, but some Norwegian, maybe some ancestors of mine who emigrated to North America. Thank you very much.
Thank you, sir. It was, as usual, an awesome lecture. Pleasure to discover the gaps that are there in what we thought is solid evidence-based. Now, we will go on to the discussion. Before that, we have doyens like Professor Corrado Moratti with us. Professor Moratti, would you like to speak a few words, or shall we go on to the...
Yes, sorry, I want to switch. Okay, here is the video. Good evening, all. Thank you for your always beautiful speech. And it's very interesting. And I could add just a little note, that my field is ventilation. And you spoke about, you underlined that the first thing to do in a baby who has respiratory distress is to start for CPAP, with CPAP. But underline that the European guidelines, they underline that in case of CPAP failure, today we can avoid to shift immediately to intubation and mechanical ventilation because a very high percentage, a significant percentage of baby could avoid mechanical ventilation if you shift from CPAP to nasal ventilation. And also the expert of these guidelines also underline that synchronized will be better. Also, they underline that synchronization is the future. So, but just a small note.
Yeah, I think that's very important, Corrado. But do you think it is should be used also in the delivery room?
I have seen in the survey that we developed that the data was published a few weeks ago on the survey that we developed on the European survey on delivery room and respiratory care also in the NICO. Some units they use also NAPPV in delivery room. Yes,
Okay.
I don't have data.
No. So, but this is clearly something we have to take into consideration when we are updating the European guidelines.
Yes.
And we are in the process starting doing that now.
Especially if you see that the baby is not going well, it needs more oxygen, we have to try. So this is what the suggestion now say, but I think we need another data that I don't have currently.
Yeah, okay. Thank you very much, Corrado, for this comment.
Oh, thank you.
Now I would request the moderators for the day, my good friends of mine, Dr. Vishnu Mohan and Dr. Murali Raj, to take over the discussion section.
Thank you, sir. And thank you, Professor Ola, for this wonderful talk. And we are really enlightened to hear from you because 4 years back, we started this webinar series from you only. So it was in between also we had you. And again, this time it was very pleasurable to have you. And one of the important thing that you have mentioned today is about the delivery room management and the gaps that we usually see in our routine practice and the evidences. So I do really feel that it's really important to keep those babies, to catch them young, as proper management of these babies in the delivery room will definitely reduce the morbidities and it actually will reduce our job in the NICU. So having said that, we have some questions in the question and answer box. The first question is asked by Dr. Vimal Vincent. In cesarean section, is there any advantage of intact cord milking or delayed cord clamping?
I didn't catch that. Sorry, Dr. Murali Rai.
Yeah, in cesarean section, is there any advantage of intact cord milking or delayed cord clamping?
Yeah, I think the connection is a little bit. I have problems hearing a question.
I think, you are already answered this in your lecture, I think. Dr. Vimal is, we will want to have his query on the difference of evidence in advantages of intact cord milking.
Oh, yeah, in C-section. No, I read it myself, yeah. Yes. I think some of the studies all have both vaginal deliveries and C-sections combined. I don't remember by heart if there is any analysis of C-section, but I would guess that there's no difference. But maybe some of you others could answer this better.
Yeah, the thing that you already mentioned
cord milking. So I think the indication for cord milking after C-section, if it's an emergency,
yes,
that you don't want to wait for delayed cord clamping, and then I think you could try cord milking, provided the baby is at least about 28 weeks. So that is my answer, and actually. We listened to a lecture by Satyan Lakshminrushma just a few days ago, and this was also his recommendation.
Yes, sir. Yeah. The next question is from Dr. Islam Abul Said. He's asking about the role of delayed cord clamping in resuscitation of diaphragmatic hernia.
That is a difficult question for me to answer because again, there's no data, so it's just speculation. And I will say that provided it doesn't interfere with the resuscitation, I would go for a delayed cord clamping also such cases. But I'm happy to hear other comments about this because I haven't seen no data on this topic. And talking about diaphragmatic hernias, it's, in resuscitation and oxygenation, we don't have much data. And so it should be a more specific interest for regarding research.
Yeah, he might have mentioned about these exit procedures where the baby is intubated before the cord is clamped and cut. Maybe, I know.
Yeah.
And next question is from Dr. Iman Badran. Can we use NAPP in delivery room?
Yeah, was my question to Professor Moretti, and he confirmed that it has been done. And so we need to see the data, but I think it's a very interesting aspect. I personally, I don't know any studies about this, but and Corrado, you don't remember exactly what he said, but it is doable, absolutely.
Yes. Dr. Harish Kashyap want to hear about you that the 5 most important resuscitation guidelines for a preterm.
The 5 most important resuscitation guidelines. Does Harish mean national guidelines or the 5 most important aspects? Or
for your points. Yeah.
Well, we've tried to follow the ILCOR guidelines, and since I'm a co-author of the European guidelines, so I tried to follow the recommendations there. Well, I have read many national guidelines, but I can't list 5 of them which are better than the others. I think most of the guidelines they're built on the ILCOR guidelines, based on the ILCOR guidelines. So
yeah, thank you, sir. Dr. Vishnu, yeah, please.
Yeah, thank you, Dr. Murli. Thank you, Professor Ola, for that wonderful lecture. In fact, we all have been learning from you over the past 4 years. And we are really privileged to have Professor Leon and Professor Moretti's presence here. So the next question is from Dr. Archana Patel. So she's asking about the ongoing trial on cord milking in HIV. So what are your views on cord milking in HIV?
Well, I'm not sure I understand the question.
Maybe she not vigorous babies.
If she means asphyxia, HIE is something we diagnose after we have clamped the cord. Always, but asphyxia. Well, as I said, if there is an urgency, there's asphyxia, you don't want to delay the cord clamping, you can do cord milking. But of course, the result of this study will be very important for our recommendations. I don't know how many of you have practiced cord milking. So provided the baby is about 28 weeks, you can do cord milking. I would say, and it seems to be quite equivalent to delayed cord clamping.
Thank you, sir. And there's another comment by Dr. Shashikant Vaidya. In the whole process of establishing breathing and heart rate, when does a mother start putting the baby on breast?
That's a very, very interesting and important question. And again, I guess we can only use our clinical judgment and experience to that. And I would say that you know the idea with intact cord resuscitation is that you can keep the baby close to the mother. I wouldn't put the baby on the breast of the mother before I felt that the baby was stable, with a heart rate that was stable and breathing pattern. So I think it's a clinical decision, but I will be happy to hear from others here your opinion about this question. Again, I don't know if there's any hard data. Of course, we want to put the baby on the mother's breast abdomen as soon as possible. So it's a trade-off here. So any other opinions?
I think that I agree definitely with you that it's a clinical decision. As soon as the baby is stable, it doesn't need to be under supervision. You can put it on the breast.
Yeah. It is an important issue to bring up.
Thank you, Professor Lo. Over to Manoj, sir. I think we have answered almost all the questions in our chat box.
Yeah. We probably exceeded the time also, but
No, muted, Manoj, sir.
Before we
May
wind, can I ask Professor Saugstad, sir, it is interesting to see the cutoff FiO2 with which to start resuscitating preterms. We are going in circles, 40, 30, now 40, now coming to 50. So what is your practice right now about the starting CPAP FiO2 when we put the preterm babies on CPAP in the delivery room?
well, again, we have tried to follow the European guidelines, saying 21 to 30% between 28 and 31 weeks, and 30% for babies less than 28 weeks. The problem is that we haven't tested out 40%, we haven't tested out 60%. There's now a study ongoing testing out 60% oxygen. So we don't have any data. So it be a guess, but I can tell you we done a lot of animal studies where we tested out 40%, 60%. And we looked at gene activation, for instance, and it seems that newborn mice, for instance, asphyctic newborn mice, they seem to have an optimal outcome when we start with 40% oxygen. So those are the only data I have. I don't have any clinical data, but we need those data, and someone who can do studies with 40% versus 60%. But you know, this will take a lot of time to get all this data, and we'll not get it in my time. So, but I hope that the younger generation can do this, because it's needed to do that.
Thank you, sir. It's very interesting. The evolution of, as the evolution of evidence goes, we go in circles sometimes, and but there are exciting things like just now we had Professor Moretti talking about synchronized NIPPV being used in the delivery room. And can I again request Professor Moretti your experience on synchronized NIV versus NIPPV, and then whether you have solid evidence for recommending synchronization in delivery room?
Yes, I think that this is would be the future when very very reliable and good methods, and very simple above all methods will be developed. But so I think we are in the good way with our flu sensor, but so there are some others, and I suppose that this could be a great help to start immediately when clearly the baby needs to breathe spontaneously. But also if the baby has some difficulties, he has to do some effort, it could be the right help. because I trust a lot in the synchronized ventilation, because the synchronization follows the physiology of the upper airways. This is one of the most complex physiology in our body. So, and not synchronized, you don't know exactly what they are doing. It's also stressing and upsetting for the baby. Probably the effect of an EPPV not synchronized is the increase of manner pressure. Synchronization is completely another thing, because you follow the complex mechanism of the open and a stiffening of the airway during respiration. So this will be the future. And so we have, I am sure that in some years, this is something that will be done everywhere. As exactly who today would ventilate a baby in a not synchronized way? No one. But may I ask another question to Professor Roll? What do you think about the caffeine in the delivery room? Do you agree that in baby that clearly have some difficulty, or need some support to start immediately or not? So there are not all the experts have the same opinion about this.
Yeah, this is a question which has been discussed quite a lot. And for instance, those who practice the Lisa or mist method in the delivery room, they also give caffeine right away. And I remember when I first time I heard that, I really questioned that, because it's not evidence-based. But we recently discussed it with Barbara Smith, who's really, I guess, perhaps the most knowledgeable in this field. And she is supporting to give caffeine in the delivery room. So as long as there's no studies, I think I will follow her advice.
Thank you.
So thank you, sir. We had a long session, now coming to end. So before we close for the day, I would like to thank all of you, to start with Professor Saugstad, the legend who has been with us from the inaugural session all throughout. Now, this is the fifth session, if I remember correctly, that we had 3 online and 2 for our conference. So, it has been a wonderful journey of discovery. Thank you so much, sir. You have been so kind enough to spare a lot of your time and efforts for us in educating the neonatology community from all over the world. And we look forward to seeing you again and again in our series, and of course in person in the upcoming national conference of the National Neonatology Forum India. Thank you so much.
Thank you, Manu. That's very kind of you. I look really forward to seeing you in India in December.
The honor is ours. We eagerly look forward to that.
I hope the same.
Yes, I would also like to thank you, Professor Moretti, Professor Elon, and all other doyens from doyens who have been joining with us for the various sessions, encouraging and then having discussion and creating interest, sensitizing us about the novel subjects, and then introducing us to the concepts of precision medicine and how evidence-based medicine cuts both ways and concepts like that. It's so wonderful. Thank you, all of you, for educating us. And finally, let me also thank all of you respected attendees who have been with us through the thick and thin. We have had sessions where people, we could not accommodate everyone in Zoom. It had to be, it had to spill over to YouTube. We had some of the sessions which were not very well attended. And then now, as even in the 4th year, now I see a great number on Zoom and also on YouTube, even now watching this session live. So it is a wonderful journey, so humbling for us. And we plan to continue this journey further. So we would close this session for today with all of your permission, and look forward to seeing you again on 18th of July for another novel topic It's actually on artificial intelligence, use of artificial intelligence in neonatology, an update by the original legend who has been spearheading this movement from the basic concepts of big data and machine-based learning to newer fields. Professor Carolyn McGregor, Professor and Dean, Research Chair in Artificial Intelligence for Health and Wellness, Ontario Tech University, and Director of Joint Research Center in AI for Health and Welfare in Canada. So another month, maybe a month later, on 18 July, we'll meet again. Until then, thank you so much, all of you.
Thank you.
Thank you, sir. Thank you.